Good morning, good afternoon, good evening, everybody. I'm Isabelle Ayoub, adult nephrologist from Ohio State University. I would like to welcome you to the ISN-KDIGO webinar targeting B cells and glomerular diseases. It's exciting to come together to review the current research and evidence on the use of B cell therapy in glomerular diseases that was discussed at the 2025 KDIGO Controversies conferences. During this session, we will focus primarily on IgA nephropathy with Dr. Floege from Germany and lupus nephritis with Dr. Rovin from the United States, both of whom are leading experts in the field of glomerular diseases and need no introduction. Please feel free to submit your questions through the Q&A feature. If you can't find it, look down on your slide and click on more and you can access the Q&A feature. We will start with the two presentations and leave the questions till the end. Dr. Floege, you may start.
Yeah, thank you, Isabelle. And let me start and share my screen. See my screen? So I will talk on B-cell modulation or depletion in IgA nephropathy, which I view as probably the most exciting upcoming treatment in IgA nephropathy. My name is Jürgen Floege, as Isabelle said. I'm from the University of Aachen in Germany. And these are my many conflicts of interest. There are many, which is pretty remarkable because 5 years from now, this slide would have been much less crowded and almost empty. So it's really nice and rewarding to see what's going on in IgA nephropathy. Whenever I have a patient with IgA nephropathy in front of me, I tell that patient, you have two diseases. You have CKD and it won't go away. It will probably need lifelong treatment. We have treatments for that: lifestyle, blood pressure, RAS inhibition, SGLT2 inhibitor. We have endothelin antagonists, sparsentan, and the most recent addition is atrasentan. And since a week ago in Glasgow at the ERA Congress, we know that finerenone will probably be a vital component of this generic CKD box as well. In the guideline, we advocate that you do not only target the CKD therapy, but simultaneously also target the immune component of the disease. We can do this with targeted release formulation budesonide. Steroid maybe in some countries, even though we all agree it has too many adverse events. Complement inhibition may be an option. But probably the most exciting and most closest to a causal therapy is B-cell modulation. So far, we have 3 modes that are being tested in IgA nephropathy: anti-APRIL, combined anti-APRIL and BAFF, or depletion of long-lived plasma cells, which are CD38 positive, but CD19, CD20 negative. We do not know whether we have any reasonable biomarkers to guide us. We don't know whether this is lifelong treatment or intermittent treatment, so there's many question marks in this slide. But as I said, this is probably the red part is probably the most exciting box that is currently under evaluation in IgA nephropathy. We have 7 drugs in this rare disease. This is unheard of. 7 drugs in advanced clinical development, 2 anti-APRIL antibodies, 3 RC-CEPs, which all target APRIL and BAFF. Note that telitacicept so far is only available in China. And we have 2 antibodies that are targeting CD38 positive plasma cells. Which of these will make the race eventually? Whether any of them is better than the other, all of that we don't know yet, but it's really nice to see that based on what we know today, they all seem to work in IgA nephropathy. So let's have a closer look. We can either target APRIL and BAFF with an RC-CEP, or we can be more specific, and the prediction in theory would be that targeting both of these should have broader activity, because some of the effects are mediated through the BAF receptor, and clearly they could be of interest for IgA nephropathy, and one shouldn't see this with an anti-APRIL antibody. However, so far, we don't have any good indication that these two approaches really differ in terms of efficacy or side effects. So let's have a look at the phase 3 data. This is probably the most advanced one, sibeprenlimab, an anti-APRIL antibody. UPCR did go down nicely over 1 year in the sibeprenlimab, stayed up in placebo. Gd-IgA1, which many believe is important in the pathogenesis of IgA nephropathy, falls by a remarkable 70%. There's no safety signal. eGFR data are still pending for the full-length trial, but preliminary eGFR data of an interim analysis at 1 year were released and show that eGFR is totally flat with sibeprenlimab. And that is, of course, what I want to have. Of course, at the end of the day, I care about GFR and not so much about UPCR. In that trial, there was also another remarkable observation. Dipstick hematuria disappeared in the vast majority of the patients with sibeprenlimab, but stayed positive in 70% of the placebo patients just as a baseline. So this comes close to true resolution and full remission of the disease when there is stable GFR, there's absence of proteinuria, and ideally absence of hematuria. And this indeed corresponds to what we are suggesting as the new aim of treatment in IgA nephropathy. Another remarkable feature of the visionary trial on sibeprenlimab is it works in every subgroup. It works independent of age, race, geographic region, high or low proteinuria, high or low GFR, SGLT2 inhibitor. It works. And this is not specific for sibeprenlimab. This is an almost universal observation in all the trials that all the new drugs seem to work in everybody. It also works, and this is important to notice, it works in every single MEST class, no matter whether you have crescents or an M lesion, an E lesion, an S lesion. It works, which is one of the many reasons why in the KDIGO guideline we say, please do not use the MEST score to decide on any particular treatment. The MEST score is nice for prognosis evaluation, but don't use it to make therapeutic decisions. As you can see here, at least sibeprenlimab and many other of the new drugs work totally independent of the MEST score. This is the alternative, atacicept, which is the second most advanced drug targeting APRIL and BAF. And again, it works in terms of lowering proteinuria, it works in terms of lowering Gd-IgA, and most patients lose hematuria. Very, very similar to what you just saw with sibeprenlimab, and suggesting, with all the caveats that this is not a head-to-head comparison, suggesting that the two approaches are very similar in terms of efficacy, implying that maybe APRIL is the more dominant target with these new drugs. No safety signal, eGFR data are still pending and will be released soon. And once again, atacicept works in all subgroups, in all GFR levels, race, region, etc., etc. It's a very universal and very consistent observation. Telitacicept was just published out of China, the interim analysis of the phase 3, and it's a little boring by now. It works in terms of proteinuria reduction. GFR is stable over the course of these 39 weeks. There were somewhat more injection site reactions, And as you would expect, IgM and IgG decreased with telitacicept, which is the mode of action. It's not specifically lowering IgA, and long-term data are pending. Let's have a closer look at the immunoglobulin levels, which, if at all, could become the one safety concern. So far, none of the arcicepts, none of the anti-APRILs has any safety concern, and adverse events are almost like placebo. But if you look, for example, in the atacicept phase 2 trial, you can see that IgA does go down and then reaches a bottom. Same for IgG, for IgM. But if you look at IgG, it keeps on falling. Yes, this is 2 years, but we also have an indication that you probably need to treat for much longer periods. And I don't know what's going to happen if IgG keeps on falling. Maybe it reaches levels which are too low. And that's important to keep in mind, that all these drugs, anti-APRIL and the arcicepts, induce humoral immunodeficiency. Fortunately, with a preference on IgA, and that's why they seem to work well in IgA nephropathy. But keep this in mind when you treat patients eventually and when you treat them for very long periods. There's one more observation. What happens if you stop atacicept? Well, this is 96 weeks of atacicept treatment. The blue columns, I'm sorry, this has gone black. And the black ones are 26 weeks after the end of atacicept treatment. So you treat for almost 2 years, blue, and then stop it and look what happens half a year later. Gd-IgA goes back, IgA goes back up, IgG normalizes. That's nice to see. IgM goes back up. So this is not really scary, and there may be some persistent treatment effect. But what is scary is this. In the next half year after stopping atacicept, these patients lost almost 5 mL of GFR in half a year. So it almost seems like there's an accelerated GFR loss when you stop this treatment. And this, of course, has implications on how we design treatment in the future, and we don't know how long you have to treat. A fundamentally different approach in IgA nephropathy is targeting long-lived plasma cells with a CD38 antibody. This is the phase 2 trial of felzartamab. And if you just focus on the orange line here, this is 9 infusions given over 20 weeks. And you can see that proteinuria decreases, but then we stop treatment. And look at that. Proteinuria stays low for the remainder of 2 years, whereas placebo doesn't change at all. So that is a totally different setting. Here you don't need continuous treatment, and here proteinuria doesn't go back up again when you stop the treatment, but you rather deplete somebody of long-lived plasma cells for 20 weeks, and then you have this very long-lasting effect. In fact, we don't know how long this effect would last because we simply stopped the trial at 2 years. GFR went down with placebo, but again, if you focus on the orange line, it went down a little bit, but much less with the 9-dose treatment regimen of felzartamab. The phase 3 trial is just ongoing as we speak. There's another observation, and very interesting one in that trial. If you look at immunoglobulins, felzartamab, like anti-APRIL and the arcicepts, induces humoral immunodeficiency, but IgG levels already start to recover while we were still treating the patients. IgM recovers right after, and for some reason, IgA levels stayed decreased for the remainder of 2 years. And very interestingly, Gd-IgA normalized, so you have a dissociation. Proteinuria stays low, IgA stays low, but Gd-IgA goes back up. This ties into an ongoing discussion. Should we really target Gd-IgA or total IgA in IgA nephropathy? And I think at the present time, this is somewhat unresolved. So coming back to my introductory slide, this is probably the most active and most exciting area of treatment that we have right now. But at the horizon, there's something even more exciting, and it's an IgA degrader. All of these selectively deplete immunoglobulins or immunoglobulin-producing cells, but you do induce some degree of humoral immunodeficiency. Here, there will be new drugs that selectively remove IgA from the circulation, and only IgA and only from the circulation. Here's one of these molecules, which is developed. It inhibits binding of the IgA receptor, of IgA to its receptor, CD89. And at the same time, it's a sweeping and recycling antibody. So it's a super efficient antibody that binds to the IgA, is taken up by the cell, dissociates from the IgA, and the cell then spits it out again, and it's ready to remove more. And with this remarkable antibody technology, you can see this. This is a healthy volunteer after a single dose of this sweeping antibody, and you can see that IgA levels go down to essentially zero after one injection and stay low at essentially zero for 1 month. So this is a really exciting development, and hopefully these drugs will make it to the market. So that was IgA nephropathy. Thank you for listening, and I hand over to Brad for his continued talk on lupus.
Thanks very much, Jürgen. And let me pull my screen up. I'm going to talk about lupus nephritis in the context of B-cell targeting therapies. And these are my disclosures, similar to Jürgen. They would have been empty several years ago, but now we have so many new trials in glomerular disease. It's really a great time to be in this area. So in June of 2025, as Dr. Ayoub indicated, we had a Controversies conference in Panama City, Panama. And this was to talk about B-cell therapeutics in glomerular diseases. This conference report is now available in Kidney International. And this conference was needed because the use of anti-CD20 targeted therapies is now very commonplace, as you all know, in the management of podocytopathies, membranous nephropathy, ANCA-associated vasculitis, and lupus nephritis. As you just heard from Jürgen, targeting B-cell survival factors and anti-plasma cell drugs are proving very effective in IgA nephropathy. He didn't discuss membranous, but they're being investigated in membranous nephropathy as well. Cell therapies with CAR T cells leads to rapid and sustained and treatment-free remissions in lupus nephritis and other autoimmune diseases. So given this broad choice of B-cell therapies with different targets, different mechanisms of actions, different toxicities, it's become really important to understand how they work in glomerular diseases and which therapy or therapies may be best for which disease. Okay, so this is a figure from the article that you can look up, and you can see here, this is the entire B-cell lineage going from the stem cell in the bone marrow all the way back to the bone marrow in the CD19 negative plasma cell, with all of the peripheral B cells listed and their surface antigens. And I know this is a little bit hard to read, but it lists currently all of the B cell therapies and which of the B cell lineages they target. And so you can very easily use this as a reference to look up what cell type you can hit with your therapy. And as you can see, most of these therapies hit multiple cell types throughout the B cell lineage. So I want to focus on something for today that came out of the conference that, and it's in the context of lupus nephritis mainly, that may be new to the nephrology community in terms of understanding. And this is three concepts: deep B cell depletion, immune reset, and disease cure. And I want to sort of do this to level set our thinking of how we might apply B cell therapies now and in the future. So, to just give a little bit of a historical perspective, B cell depletion got off to a pretty shaky start. We looked at anti-CD20 rituximab in patients with active proliferative lupus nephritis many years ago. This came out in 2012, and this trial, called the LUNAR trial, failed. And what you see here is if we add rituximab to mycophenolate and glucocorticoid, and compare that to placebo, we did not improve the complete renal response rate. There was a numerically higher number of partial renal responses, and the number of no responses was about the same. So this trial didn't work. However, several years later, we reanalyzed the data from the LUNAR trial, and this is shown in the graphical abstract here from the article. And about 78% of the patients had complete peripheral B cell depletion with rituximab. And those patients actually had a 47% complete response rate at 78 weeks, compared to 22% of the patients not having complete B cell depletion peripherally, and only 13% of those patients had a complete response rate. So this post hoc analysis of the LUNAR trial may have been the very first time we started to think of the concept of depth of B cell depletion as being important in the treatment of lupus nephritis. Well, perseverance paid off, and so over a decade later, we used a different B cell depleting agent, obinutuzumab, which is also anti-CD20, but is a little bit more efficient at peripheral and potentially tissue B cell depletion than rituximab, and I'll show you that in a minute. But these are data from the phase 2 nobility trial. And what we're showing here is that after about 36 weeks, you see a nice separation in complete renal responses in the obinutuzumab arm compared to the control arm. And this lasts out for 104 weeks with an effect size of 20% greater in the obinutuzumab arm. So we then took this to the phase 3 Regency trial. This was recently published and led to the approval of obinutuzumab for the treatment of lupus nephritis. This is the trial design. Individuals got obinutuzumab or placebo on a background of mycophenolate, glucocorticoid, and hydroxychloroquine. This is the dosing of the placebo or the obinutuzumab. And this is the bottom line of the trial. Obinutuzumab patients had about 46.4% complete renal response compared to 33% in the placebo group. And this was a 13.4% difference that was statistically significant. Now, going back to the original diagram, these are the cells that are targeted by anti-CD20 therapies. And I've just made this table to show you that type 1 anti-CD20, which is rituximab, or type 2 obinutuzumab, actually target the same cells, which sort of makes sense. The mechanism of action of killing for both is anti-dependent cellular cytotoxicity, but rituximab uses complement also to kill the B cells. And of course, in a disease like lupus, where complement may be depleted or used up, that may not be a sufficient killing mechanism. Whereas the type 2 or obinutuzumab induces programmed cell death. The other thing is that rituximab can be internalized and neutralized by the cells. And obinutuzumab is neither internalized nor neutralized, so it's available to kill and kill again. Okay, now let's see a little bit of a comparison between obinutuzumab and rituximab. I made this chart based on data from Nobility and Lunar, so you can't compare these directly. So if you're statistically inclined, you can say you're making a mistake. You can't compare these. But in general, I wanted to show you sort of the kinetics of B cell depletion with obinutuzumab versus rituximab in a clinical trial. You can see that very quickly, by 2 weeks, almost everyone has a peripheral B cell depletion with obinutuzumab, and lasts all the way for a year. As you can see here, this takes a long time or a longer time with obinutuzumab to get a good level of B cell depletion. You see the maximum at about 3 months, and you see that patients start to recover their B cells more quickly. What I think is more important potentially is that if you look at the tissue level, and these are patients who received obinutuzumab or rituximab and 6 months later had a lymph node biopsy, you can see that in the lymph nodes, CD19 and CD20 are still present in obinutuzumab, but they're really still present in rituximab, suggesting that obinutuzumab results in better B cell depletion in the tissues and the periphery than rituximab. And this has been borne out in looking at cancer being treated with obinutuzumab or rituximab in terms of residual disease. So you can ask the question, does tissue B cell depletion account for the superiority of obinutuzumab versus standard of care? And what I'm showing you here are unpublished data. We're looking at spatial transcriptomics in patients who had an initial kidney biopsy for lupus nephritis. And I've targeted here the B cells. And you can see that these patients have a variety of number of B cells in the kidney tissue, but certainly more on average than a healthy individual. And after treatment with standard of care therapies, this would be cyclophosphamide or mycophenolate, you can see that the B cell numbers have gone down, but there are still B cells in the kidney tissue. We did repeat biopsies in the Regency trial after obinutuzumab. These were done at about 76 weeks. And what I'm showing you here, this is the obinutuzumab, 3 patients, and these are 3 placebo patients. The green are B cells stained with CD79. The red are plasma cells stained with CD138. Unfortunately, that also stains tubular cells, so you have to be a little bit careful in interpretation, but you can see that after obinutuzumab, there's no more green cells left and there's very few red cells left, whereas in the placebo group, there's plenty of green cells and red cells left. And if you look at the graphs below, you can see that patients had a variety of B cell amounts in their tissue, but in general, everybody lost, or the B cells at week 76 after obinutuzumab went away. With placebo, you see that they don't really go away. And there was a decline of about 50% in the plasma or the antibody-producing cells in the kidney in the obinutuzumab treated patients, probably reflecting short-lived plasmablasts. So now let's say we talk about conventional therapy, and I'm talking about conventional therapy, including the new drugs, voclosporin, belimumab, and obinutuzumab, and we can ask how we're actually doing with these therapies. And you can see that at 12 months, you have about a 44% complete response rate compared to a 23%. With voclosporin, belimumab 30% versus 20%, and about 46% versus 33% for obinutuzumab. Let's back up and say, how does that compare in reality with the drugs we had before we started using the so-called triple therapy? So mycophenolate, or cyclophosphamide plus glucocorticoid, plus one of the newer approved drugs for lupus, voclosporin, belimumab, or obinutuzumab. And so I took all these data from older trials, looking at either mycophenolate, urolupus, low-dose cyclophosphamide, and high-dose cyclophosphamide. And if you look at just the standard of care arm, just what we would have treated patients with before, you can see that the 1-year complete renal response rate using mycophenolate was about 35%, and the 1-year complete renal response rate using low-dose cyclophosphamide was about 34%. So that is pretty comparable to what you see here with the newer triple therapies. Now, I'm not saying that this doesn't suggest that the newer therapies are not significantly better for our patients, because they do other things besides this arbitrary target of a complete renal response. They decrease flare rate, they tend to maintain GFR. So there's lots of important things that are not listed here. But in terms of the complete renal response rate, we have only made incremental improvements. So this brings me to cell therapies. CD19 CAR T cell therapies, as you all know, are being used all the time now in treating malignancies, lymphomas, and leukemias. And these are CAR T cells, so these are in general the patient's cells. They're actually manipulated in vitro to then be put back into the patient's, target CD19 expressing B cells, and kill the B cells. And so I'm showing you the first article that really stimulated attention in the nephrology and rheumatology community. This was from Georg Schett's group in Germany, anti-CD19 CAR T cell for refractory lupus. These were 5 patients. They had lupus and lupus nephritis. They were treated with this CAR T therapy and went into remission within a few months and had minimal adverse events. Okay, and I'll show you the data in just a minute. This is the 2-year follow-up of these patients, and at 2 years, 100% of these patients, they added 3 more, so a total of 8 patients, had achieved complete renal response in 3 months, and they had no lupus nephritis relapses, and they were off all immunosuppression, including hydroxychloroquine. Now just let that sink in for a minute. Everyone responded, and they remained in drug-free remission for 2 years. Okay, how does the cell therapies work? Well, they work very fast. This is the data from the original paper. You can see that proteinuria goes away within 3 months. You can see that CD19 goes away within a few days. So peripheral B cells are gone very, very quickly. But look at this. This is really interesting. The solid lines are the B cells coming back. And you can see that with the CAR T cell destruction of the B cells, or elimination of peripheral B cells, they come back within about 3 to 4 months in all 5 patients. So what's really going on here? And I would suggest to you that tissue B cell depletion may be the key to the success of cell therapies. And so I'm showing you the picture I just showed before. This is obinutuzumab and a lymph node. This is a T cell engager, which we're not going to discuss except at the end, but just look at obinutuzumab. This is rituximab. These are the B cells, CD19 and CD20 B cells remaining after therapy. And this is what remains in the lymph nodes of patients that are treated with CAR T cells. There isn't a single B cell left. Furthermore, if you look at the germinal centers and the lymphoid follicles in patients treated with CAR T cell, you see that this is before CAR T cell therapy, and this is after CAR T cell therapy. You see that the follicular dendritic cells go away, the T follicular helper cells go away, and proliferating cells go away. And if you look at the same thing, again, comparing CAR T cell to obinutuzumab, you see that OB does a pretty good job, but it's not nearly as clean as what these lymph nodes look like after CAR T therapy. So this now brings us to the next concept, which is immune reset. Immune reset was coined after CAR T cells began to be studied in autoimmune disease, and it's become the goal of treatment for cell therapies and other agents designed to achieve deep B cell depletion, deep meaning tissue level, beyond peripheral B cell depletion. Immune reset refers to the disappearance of autoantibodies, elimination of IgA and IgG of memory cells, and repletion of B cells with a naive phenotype, so CD19, CD27 negative, as opposed to memory B cell phenotype, CD19 positive, CD27 positive. The conference participants suggested reset is the complete depletion of clonal autoreactive B cells, depleting B cell memory. And this is a prerequisite for cure of autoimmune disease. So here's some evidence. This is what happens when the B cells repopulate after CAR T cell therapy. They're almost all naive B cells. Very few of the memory B cells come back. But look, the same thing sort of happens with obinutuzumab. This is from the Nobility trial. This is the last obinutuzumab dose at 24 weeks. Memory B cells are down here, and they're barely coming back. And after about a year, you can see naive B cells are coming back. This is the spoiler. So a spoiler alert for this idea of immune reset. These are other autoantibodies that are not depleted in patients with autoimmune disease. These aren't all lupus patients after CD19 CAR T cell therapy. These actually go away if you use CD19 plus BCMA CAR T cells, which target long-lived plasma cells, suggesting that after CD19 CAR T cell therapy, there are still autoantibodies present. They're not necessarily causing disease at the time we're looking, but can we really say we've reset the immune system if autoantibodies are still present? Okay, now let's wrap up with this idea of cure. Cure at the conference was defined as the absence of clinical, immunologic, and histologic signs of disease activity while the patient is off all immunosuppressive therapy. Cure is a reversion of the immune system to the premorbid state when medications were unnecessary. At the conference, we had no consensus about how long you had to be in this state to call cure. It was suggested lifetime. However, you know, when you treat a patient with cancer, if the cancer doesn't come back after 5 years, they're sort of called cured in many cases. I would ask the question, can we call cure if autoantibodies persist? I don't know the answer to that question. However, we do have some long-term follow-up data from the CAR T cells therapies, and it's pretty encouraging. I showed you this, the 2-year results of the George Schett data for the 8 patients. Now, he's presented these data in various forums, but at the 4-year mark, many of these patients have reached the 4-year mark. They still remain in complete remission of their autoimmune disease off of immunosuppression. So, short of a lifelong cure, I would suggest that being free of disease activity and or being off treatment for at least a few years should be considered a clinically meaningful treatment outcome and attainable at this stage in how we're treating patients. Okay, cell therapies may not be the only way to achieve immune reset. I'll just talk about T cell engaging antibodies. There's bispecific engagers. These are made by taking for example, the business portion of an anti-CD19 monoclonal antibody, fusing it with the business portion of an anti-CD3 or T cell monoclonal antibody. So this bispecific then binds T cells and B cells, bringing them together and eliminating the target B cell. However, you can imagine you can take this part, which is the part that binds to the T cell, and then attach any other surface antigen to it of a cell type that you want to eliminate, and have very fine cutting out and killing of specific B cells in the circulation and possibly in the tissue. And this could even be B cells expressing a specific antigen, for example, PLA2R in membranous nephropathy. So exciting times for the future. So let me finish up with the last figure, and this is again from the article, and this is a summary of B cell depleting strategies for lupus nephritis. I start out here with the first generation monoclonal antibodies, and I've sort of given a heat map of availability, cost, and safety and tolerability. And we go all the way up to CAR T cells, and this increasing is depth of B cell depletion, and we have peripheral B cell depletion with the first generation monoclonal antibodies. We have increasing peripheral and T cell depletion with the humanized and optimized monoclonal antibodies like obinutuzumab, bispecific T cell engagers, and then the CAR T cells, which are sort of the atomic bomb of blowing up lymphoid structures. We know that there's availability issues here. These monoclonal antibodies are available off the shelf. CAR T cells, at least how they're being used now, have to be taken from a patient, manufactured externally in vitro, and then delivered back to the patient. And this takes a finite period of time, although that time frame is getting shorter. These are also modified, generally using viral vectors. The cost is moderate for the monoclonal antibodies and extremely high for the cell therapies. And then, of course, you have safety and tolerability. We're all pretty aware of the safety of the B cell antibodies. However, the CAR T cells can have cytokine, and the B cell engaging drugs, the T cell engagers bispecifics, can have cytokine release syndrome, a neurologic cytokine release syndrome, and a new syndrome where B cells are destroyed in the tissue, and you can actually have acute renal failure, but it generally gets better. So I'll stop now, and hopefully my colleagues will come back and we'll answer some questions for you. Thank you very much.
All right, thank you, Dr. Floege and Dr. Rovin, for the fantastic presentations. I have a few questions for both of you. We'll start with IgA questions. Dr. Floege, why do you think rituximab did not work in IgA nephropathy, and do you think obinutuzumab will do the work?
Well, we only have one randomized controlled trials, and that is Richard Lafayette's study, which was published probably something like 10 years ago. It was negative. There was not the single indication of an effect after 1 year of treatment. And the notable thing that Richard published was that while there was adequate depletion of CD19 cells, they were gone. IgA levels didn't change, nor did galactose deficient IgA. So it seems that whatever is causing IgA nephropathy is not made by CD20 positive cells. And thus, by implication, I would not expect that OB would be more effective than rituximab in IgA.
So you think it's not the depth of CD20 depletion, but rather targeting a wider subset of plasma cells?
In that trial, CD19 counts were, I don't remember exact numbers, but they were way down. So it was documented good depletion.
Okay. I have two similar questions for the treatment of IgA with the new therapies that are available. Would you consider steroid first? And if it fails, then consider the novel therapies? And the other similar question, how would you weigh in between using other agents like complement inhibitors versus B cell depletion or modulation?
Steroids, I'm from Germany. As you may know, we have run the Stop IgAN trial in Germany. There was not a hint of an indication that steroids did any benefit. If at all, they transiently lowered proteinuria, but that was all we observed. We did not avoid a single case of dialysis. So in a Caucasian population, and there are 3 more retrospective European studies all suggesting that steroids don't work in Caucasians, all consistently showing you increase adverse events. Steroids seem to work in Southeast Asians. You delay dialysis by 2.5 years with a half-year course of steroids, but it comes at the expense of sometimes lethal infections. We had 4 or 5 infection-related deaths in the testing trial. all in the high-dose steroid phase. So even in Southeast Asia, steroids are no longer the treatment of choice. Would I add complement inhibitors? Well, it's a little ambivalent. Complement inhibitors limit inflammation, but if you can reduce the IgA that is causing the inflammation, to me, that seems to be the more plausible, almost causal therapy. What we don't know is whether it would make sense to add a complement inhibitor if you do a kidney biopsy today, you see loads of inflammatory changes and C3 tomorrow, and on next week, Monday, you start a complement inhibitor. Kind of an induction therapy in addition to anti-APRIL to bridge the phase until pathogenic IgA is low. This trial has not been done, obviously, and so far we would all up-titrate RAS blockers first and give it an SGLT2 inhibitors, and by the time that you are done with that, the biopsy is historic and you don't know how much complement is in your biopsy any longer.
And the other follow-up question is, should we up-titrate these foundational therapy and wait, or start B-cell modulation from the beginning?
That's the big question, and it's a very costly question. Conceptually, it would make sense to target both right now simultaneously, and that's what we say in the guideline. But I acknowledge that the new therapies some of them are extremely costly, and I don't see a reason why you shouldn't be able to treat for, let's say, 6 to 8 weeks with a RAS blocker, SGLT2 inhibitor, maybe finerenone, maybe an endothelin antagonist, until you contemplate the use of an anti-APRIL or an Accept. That would certainly make sense. If you can induce full remission very quickly, there may not be the need for one of these newer drugs.
There is a comment and the question on they said EGFR bump that is observed in the APRIL or APRIL-BAFF inhibitor. Is it different mechanistically than the EGFR bump observed in the budesonide or Nefecon studies?
We don't know that. That's an excellent question. It's very notable. I mean, the EGFR bump is bumpy. It's really tiny, 2 or 3 mils. But it's very notable that budesonide causes it, and many of the other new drugs seem to increase GFR a tiny little bit, suggesting that there is an element of reversibility there that is related to inflammatory changes and that you really can dampen. It's not a lot, unfortunately, but it's a very consistent and interesting finding. A similar finding has been seen in testing, but there, testing methylprednisolone, but there the discussion was always, is it a pseudo increase in EGFR related to high-dose steroids causing muscle loss? And that would falsely elevate GFR because you produce less creatinine. That is certainly not the case for budesonide. The urine excretion of creatinine does not change, suggesting that muscle mass is not affected, and certainly not the case for anti-APRIL and things like that.
Now, talking about GFR, you showed interesting data with the atacicept 96 weeks and then the follow-up weeks after therapy. Are you concerned or surprised with the quick drop in EGFR after that? And do you think B-cell therapy have maybe a hemodynamic effect, and that's why quickly the GFR dropped after holding therapy? I mean, within a few weeks, we had a drop of 4 ml.
I honestly can't see how B-cell therapies should affect hemodynamics. I would be totally with you if you're talking about endothelin inhibitors and things like that. They have definitive intraglomerular hemodynamic effects. B-cell therapies, I can't imagine. this must be resurgence of inflammation and really flaring IgA nephropathy. That's my best explanation. And note that we are looking at 26 weeks, so it's half a year after stopping the treatment. That's quite a long time already. But yes, I'm concerned by that because the implication obviously is you have to treat for a very long time, whatever that is.
All right, thank you. There are so many more IgA questions, but I'll move on to Dr. Rovin. And if you can stay further, we can go over the rest of IgA questions. So Dr. Rovin, there is a question. We see cyclophosphamide doing better than MMF in our practices. Why do you think in the studies you showed that they have equal effect? The cyclophosphamide MMF response.
Yeah, that's sort of been what the publications have shown. When you do them in a paired trial under controlled conditions, cyclophosphamide and mycophenolate do about the same. So we all see little variations in our practice that's anecdotal. I don't know that that can be translated to the broader sort of lupus population. And it may be that in some populations, because of genetics, ethnicity, they'll respond better to one drug or another. But we tried to say that with rituximab in the very first study, the LUNAR study, and that really wasn't the case. So I don't know that I have a good explanation for that.
And I agree with you that it's really dependent on some ethnicities because some of them MMF works better than cyclophosphamide. Another question, do you see earlier B cell depletion with induction is better in everybody or only certain cases?
Well, the induction therapy with obinutuzumab is quite quick. The induction of B cell depletion with CAR T cell is quite quick. And those have been the studies that have shown benefit with the B cell therapies. So I think the quicker you can eliminate the B cells, yes, the quicker we can move towards allowing the kidney to resolve its inflammatory lesions and start to heal. So I think rapid B cell depletion is actually useful. We don't really deplete B cells a lot with belimumab, but we do deplete some B cells. And as you know, if you remember the curves from the BLISS-LN trial looking at an anti-BAFF in lupus nephritis, it took the curves quite a while to separate between belimumab and placebo, and of course, much less B cell depletion, much longer time frame. So yeah, I do think rapidity is important.
Right. There is a question on should we combine belimumab with other B cell agents like rituximab in lupus nephritis?
Yeah, I do think so. We did and have done and are doing experiments like that. The first one was not particularly successful, although I'm not sure that the trial was designed to look at the right endpoint, which was a trial done years ago with the Immune Tolerance Network, adding belimumab to either cyclophosphamide depletion of B cells or rituximab. I think the idea of adding belimumab to another B cell depleting agent is because belimumab has some other intrinsic properties that we've seen that are quite useful, which is one, preventing major flares, including lupus nephritis flares. And also it tends to stabilize GFR, similarly to what Dr. Floege was showing with the B cell drugs in IgA nephropathy, which was quite exciting. So I do think that if the author of this question is getting at this, can we start to think about using our new drugs in various combinations other than what we've seen in the clinical trials? I do think we have to investigate that, but this would be something that I think would be very appealing. Can we deplete the B cells? Can we maintain them with a drug like belimumab, where we have decades of safety data? And that is certainly a possibility, and it should be investigated.
And there is a follow-up question in this regard that do you think a combination therapy with BAFF-APRIL or BAFF alone with anti-CD20 is a better initial option than going straight to a CAR T, for example?
Well, a little perspective on that. We actually used a BAFF-APRIL in the past, added to mycophenolate and steroids, and that trial got shut down fairly quickly because of the toxicity. That's not to say that I don't think a BAFF-APRIL at this point couldn't be used safely. What we learned was that the addition of the BAFF-APRIL, on top of high-dose glucocorticoid or high-dose mycophenolate or high-dose cyclophosphamide, really promoted infections quite quickly. So I think we would have to take an approach where we modulated the background therapy to some extent to avoid these side effects. I do like the BAFF-APRIL approach. If you look at some preliminary data that has been published in bioarchives, it's quite interesting in mice, of course. But you look at a BAFF-APRIL versus an APRIL alone, you actually get nice depletion of germinal centers. So you're getting the kind of deep B cell depletion that we are seeing with the CAR T cells. Now, it may not be as extensive, right? And of course, it's a mouse model. But I think the point is that we can start to think about using other things before we get to the CAR T. Now, let me give another side of this opinion. If we can do CAR T safely, quickly, and off the shelf, and we are seeing prolonged responses without any immunosuppression, I think this would be ideal in patients who have new lupus or new lupus nephritis and are starting their lives out. I mean, as you know, most of these are young women. They maybe want to have a family, they want to start a career, and to have 4 years, 5 years, maybe longer without any immunosuppression right from the beginning might not be a bad idea. And I do think this is feasible. We are starting to look at other types of cell therapies that might be off the shelf, like allogeneic CAR T cells, where you don't have to manufacture them individually for each patient. That may be an answer for the future. And if the toxicity is low, and we don't have to use as much lymphodepletion for the audience, before you give a CAR T cell, currently you give cyclophosphamide and fludarabine to wipe out all the lymphocytes. There's a lot of immunodepletion. If we don't have to do that, and these therapies can be used safely, I think they might become much more used in patients without necessarily refractory disease where they're restricted right now.
Yeah. Do you have any information on deep immune reset and their effect on vaccination?
Yeah, so it's really interesting. If you look at the CAR T cell, the CD19 CAR T cell, you still maintain your vaccination response because you are not eliminating the CD19 negative long-lived bone marrow plasma cells. To kill those cells, you need to add something like either anti-CD38 or BCMA, which is another B cell antigen. And in fact, if you look at some of the dual specific CAR T cells, so there's a CAR T cell that was being trialed in Asia that's CD19 plus BCMA targeting, so it kills everything. those patients would need to be revaccinated. But with the usual CAR T cell therapy, your long-lived vaccination responses should remain intact.
Any data about podocytopathy post-CAR T therapy? And same question, but different kind is if we have to monitor CD19 and IgG with B cell depletion.
Okay, well, I'll talk about podocytopathies first. It's really interesting that so far in the CAR T world, the patients who have not necessarily had a full remission based on proteinuria, which I know is artificial, and we talk about needing better biomarkers, those are often the patients who have had a class 5 component, so a podocytopathic component. So it's really interesting as to whether or not the CAR T can affect patients with podocyte disease. Now, if you're asking specifically, do podocytopathies recur after CAR T? There was one patient in the George Shett group. I don't know if you all remember the figure where the proteinuria spiked up. That patient had a proliferative lupus nephritis, and then when the proteinuria spiked, they were rebiopsied and they had developed a podocytopathy. Again, suggesting that with this therapy on board, maybe antibodies that damage the podocyte somehow still are around, which is really sort of interesting, but I don't think there's enough data on that. In terms of monitoring, we don't have official guidelines on the monitoring yet, but I do monitor with B cell depletion. I monitor peripheral B cell counts. I use that to help guide my redosing for a lot of patients with GN, not just lupus. And then I also do monitor IgG levels periodically, especially if the patient is having recurrent, for example, colds or viral infections. And if the levels are persistently quite low, I will supplement them with IVIG, and that usually takes care of the problem. But these are all really important questions that need to be worked out. And this is similar to what Jürgen was saying. We don't know what happens after long-term therapy with the B cell modulators and IgA. Does IgG keep going down? And should we monitor those levels as well? And do we need to intervene when these levels get low? All valid questions that we really need to work on.
And as a follow-up question for the toxicity, do you use pneumocystis prophylaxis in your patients with B cell depletion, like obinutuzumab?
I do. I use, I know it's not very popular, but but I do use pneumocystis prophylaxis as long as the patients remain B cell depleted.
And there is a question on the duration of therapy. How long do you keep your patient on B cell therapy, and would you do treatment vacation?
Well, that's really a very difficult question. We don't know how long to keep the patient on B cell therapy. I do, as a routine, and I'm talking about lupus nephritis now, I do like to see the patient having had a response for a prolonged period of time. I do treat for about 3 years or 4 years in total with immunosuppression. And then I like to slowly remove drugs and see if I can maintain a drug-free, not totally free, I keep hydroxychloroquine on board, a immunosuppression-free remission. So again, an excellent question for which we don't know the answer.
All right, and since Dr. Floege left, I may ask you a couple of questions on IgA for pregnant women. Is there any data on the use of these B cell modulating agent? And if not, would you consider plaquenil or other agents during that time of pregnancy?
So there's no data that I know about other than accidents with the B cell modulating drugs, metastasapt or anti-APRIL, for pregnancy, and it's not recommended. There are some data for belimumab in patients with lupus, and belimumab did not seem to result in anything significant. It's still not been studied adequately, I would say, although I know that in the rheumatology community, this is being investigated. I am very cautious with patients with pregnancy. Hydroxychloroquine, I maintain. That's safe in pregnancy. I do maintain a calcineurin inhibitor, for example, in patients with lupus. Interestingly, voclosporin, the pill contains alcohol, and so it's not recommended for use in pregnancy because you have to take 6 pills a day. So I usually use tacrolimus. The amount of alcohol is small, but still maybe something to think about.
And for the attendance, the CNI that Dr. Rovin is mentioning is mainly for lupus, not the IgA.
No, yeah, this is not for IgA. I'm talking about both now. I think pregnancy is really hard to work with IgA. I think that we know steroids are okay. We're not entirely sure about the enteric steroid, but I would suggest to you that they are not. I'm not sure that an enteric steroid would be any different than peripheral steroids in pregnancy for IgA nephropathy, but again, that needs to be tested. So really a very limited selection during pregnancy.
Yeah. And Dr. Floege, he showed data on relapse of the galactose-deficient IgA on his back. Hey, Dr. Floege, can you hear us?
I'm back. I'm sorry, Michael.
Okay, that's okay. Can you hear us well?
I hear you.
Okay. There is a question. You showed that the galactose-deficient IgA kind of rebound when we stop B cell modulation. And the question is, does the rise in galactose-deficient IgA lead to a relapse?
Well, good question. Certainly not in the phase 2 trial that we've published. The notable thing there is you can dissociate the rise in IgA from stable disease, stable benefit on proteinuria. So as I said, this is one of the arguments why there's an ongoing discussions is Gd-IgA1 really the central culprit in IgA nephropathy or not? And if you look in one of the latest Kidney International issues, there's an experimental paper out of Beijing also questioning that Gd-IgA1 is the central culprit in IgA. We don't know yet.
Yeah, and they are asking if that's not the biomarker, what will be the potential biomarker for the future? Do we know?
Right now it's total IgA.
Yeah.
But there's 2 companies are running really interesting trials. It's Argenx, which I showed you with the sweeping IgA antibody. That's a pan-IgA antibody. But there's Biohaven doing a trial with a Gd-IgA1 specific antibody. And if that works, then of course the discussion is settled. Then Gd-IgA1 is the central culprit. And if you remove it, everything gets better. But that we don't know yet.
Yeah. Well, I would like to thank you both and thank you for the attendees' great questions. And until we meet again, hopefully we will have more data on the use of B cell therapy in glomerular diseases. Thank you, everybody. Bye-bye.
Bye, everyone.
Bye.